Can I just ask Dr. John Yudkin, who's worked for 30 years at the Whittington, who's now retired, a local resident, just to say a word. John? And John's family contributed to the Whittington before that.
I just wanted to speak. I've been living in Tufton Park for 42 years. I did a house job at the Whittington, I did an SHO job at the Whittington, I was a consultant at the Whittington for 30 years. My dad was a consultant at the Whittington before me in paediatrics, so there's a long way back. But I just want to ask a question to frame the discussion. Can you, Dr. Coe, give us the average bed occupancy in acute medicine over the last, say, 6 months at the Whittington, or 3 months? Do you have a figure?
So probably 90 to 95%.
About how many percent bed occupancy is there? Because when I was a consultant there, we were running at something like 90+% bed occupancy.
Yes, absolutely.
Right. And the recommended level of bed occupancy for good standard care is something around 80%. So the idea of closing 70 care of elderly beds at a time that there is already a close to 100% bed occupancy without advanced planning of care of these people in the community does seem a little ludicrous. I think we need to recognize that all of this is happening a week after this meeting, a week after the Francis report on the Mid-Staffordshire debacle. And the conclusion in the 290 recommendations was that Mid-Staffordshire was chaos because of what Brian Jarman calls managerialism, where targets, be they financial or be they new labour, waiting list or other healthcare delivery targets, become the prime focus of healthcare managers, and everybody is in fear and trembling of not keeping to targets, and the managers in the unit are so invoking fear in their work staff that nobody dares protest. Why didn't anybody blow the whistle in Mid-Staffordshire? Because they were scared. And the professional associations, nursing and medical, didn't stick up for them. Care was bad, everybody knew that care was bad, there weren't enough beds, and things were going bad because of financial pressures. Now the financial pressures there were foundations trust status. It sounds awfully familiar because that's what the Whittington's after. The financial pressures now are all of that compounded by Sir David Nicholson again making £20 billion of Chancellor's cuts, and everybody's got to stick to the target. We need to recognise that professionalism is saying we can't do it with this staffing level, we can't do it with these bed numbers, we can't reduce the bed numbers for care in the community without making sure that pilot schemes are instigating the community care beforehand. I think that we need to recognise that there's going to be another Mid-Staffordshire in Archway if we're not careful, because the targets that are being imposed by managers are responsible for potentially disastrous care. If we have pilot schemes to show that these so-called bed blockers can be looked after in the community by not just by GPs seeing them, but it's the care of the elderly at home without family support, with statutory services being cut, as Islington and Hackney and Haringey are having their budget cut year on year. the provision of statutory services is getting worse, and the concept that care in the community is going to be realistic care is just like discharging mental health patients from the long-stay psychiatric hospitals in the 1950s and 60s.
Thank you very much, John.
Thank you, John. My name is Martin Kuper. I'm Medical Director at Whittington, and I've been at Tottenham Park and Kentish Town resident for 44 years, so I beat you by 2. All of my family use the local services, and I want to keep them as good as they can be. Currently at the Whittington, our mortality on the SHME, the Standardised Hospital Mortality Index, is the lowest in the country. We're very proud of that, and it's been the lowest in the country for 6 successive quarters because of the professionalism of the staff who work there and the systems we've put in. The cardiac arrest rate at Whittington has halved over the last couple of years because of the improvements in care we've made, and we're very proud of that. However, we've also reduced the length of stay for colorectal surgery from 21 days to 10 days. We're very proud of that, and that means we need less beds for patients undergoing colorectal surgery. In Islington, we've worked with local GPs to improve the care of people with breathing difficulties this year, which has led to a reduction in admissions and a reduction in intensive care days for people with respiratory problems, and that will mean less bed days. So we're putting in the other bit of money. Someone asked where the other amount of money went in the capital. The other amount of money goes into making our day centre for people with acute medical emergencies, to invest £3 million in that, which will make our A&E better and will reduce the number of people that need to spend unnecessary days in hospital, and that will reduce the number of beds we need. If you can not be in hospital safely, that is better for you than being in hospital unnecessarily. So we have a number of schemes that exactly what we're doing is piloting, and if they translate into a reduction in the number of beds we need, we will reduce the total number of beds in the hospital. We're trying to make the care better, not worse. And by improving maternity, by improving the treatment of patients in for the day, by delivering better care with our local GPs, better integrated care, we can reduce the total number of beds we need and concentrate the resources where they're most valuable.
So what you're doing is full up of sign outside, no vacancies. Well, you're full up, you're going to have a sign outside, no vacancies.